Our next speaker is Dr. Sharad Bhomaj. He's a senior vitreoretinal specialist from Meerut. He is going to speak to us about whitish, yellowish veils seen on fundus examination. What are we dealing with?
तो दिखता है क्या? Yeah, so there's a, a lot of overlap between the topics. So anyway, what we are dealing here with some whitish or yellowish opacities in the vitreous, and what are the signs which you see on fundus examination. So it could be either a vitreous degeneration, as discussed earlier, either a standalone age-related vitreous degeneration, or associated with some other ocular pathology like schisis, FEVR, sticklers, all those kind of things. It could be a another kind of retinal degeneration like asteroid hyalosis or synchisis. It could be vitreous inflammation like vitritis, or sometimes even a white spot can be an old vitreous hemorrhage. So, as discussed, this is the most common vitreous opacity which you see in the fundus. That is a vitreous floater, which is a Weiss ring. So, if it is a not an acute condition, obviously you will have to examine all these patients with scleral indentation. But if it's not an acute condition, maybe it's not that sinister. And in some patients who are undergoing YAG capsulotomy, it could be reducing the incidence of detachment post YAG. If there is no PVD, they have got a high risk of developing a retinal tear. So the most important thing, as discussed by all the speakers, is that examine the fundus properly so that you don't miss the retinal tears or a subclinical detachment. So it could be a very serious condition. You can have a macula on detachment and even a giant retinal tear, which is macula on. So the thing which we have to do is the laser, and you can save the patient from further problems. So the next kind of conditions which you see is that when you examine the fundus, you see floaters, but you see multiple lattices. So in this kind of lattices, which are very irregular, radial, paravascular, multiple, oblique, not necessarily circumferential, they indicate that this patient is having a serious vitreoretinal disorder. So if this patient are having coexistent systemic features like cleft palate, cleft lip, sensorineural hearing loss, all these kind of systemic associations, it could be a case of Stickler syndrome. So in these kind of lattices, we don't do anything, but we do observe. So we don't actually treat these patients, we observe. So unless there are retinal tears, we don't treat. So more extensive the lesions, we be on the defensive side. If you have limited degenerative lesions with holes, we treat those patients. So if you have multiple lattices and also you have pigmentary retinal degeneration, then along without a systemic manifestations, this could be a Wagner syndrome. So something you will have a radial lattices and other lot of lattices in the peripheral fundus, but along with that you will have pigmentary changes in the fundus. So these are patients of Wagner syndrome. So next pathology which you can have with whitish or vitreous opacity, which is not the routine vitreous degeneration, is the FEVR. So this is a very important disease, quite high association with myopia. It can be unilateral and sometimes even bilateral. The most important thing is that you can have a disc drag. So if you see a disc drag and you cannot reach the vessels in the periphery, so there will be a varying area of avascular retina where the vessels, if you trace to the periphery, these vessels are stopping short, they are not reaching the aura. So when you examine the peripheral fundus, you will find that these vessels are stopping just short of the periphery. So the extent varies a lot. And these patients can sometimes develop a vitreous hemorrhage or a vitreous degeneration, and this on the second top, this is a patient with a FEVR presenting with a vitreous hemorrhage, which is old. So he's got white floaters inside the eye, and it's an old vitreous hemorrhage. So this is a patient with 360-degree kind of avascular retina in a FEVR patient. So these patients need laser treatment to the avascular retina depending on the individual scenario. So some patients who are asymptomatic and don't have much kind of signs, very small asymptomatic patients, they can observe. So observation versus treatment that you have to take the decision in due course of time after detailed follow-up of the patients. Some of these patients may not always have a disc drag or vascular problems. They can directly present to you with these avascular areas. And obviously detachments are very common. So this is one of the patients of FEVR which presented with floaters, and his vision is 6 by 6, but you can see the extent of avascular retina is reaching almost couple of disc diameters away from the fovea. So this is the patient which we need to treat and need to follow. So the next kind of signs which we see with a vitreous floater inside the eye could be a retinoschisis. So what is actually happening in the retinoschisis is that there is a split in the retinal layers, and because the split is occupied by a transparent retina, this inner part of the retina is the blood vessels which are there, they are appearing floating in the vitreous cavity. So you will see floating blood vessels or floating vitreous floaters. So you will have like this, and when you can see these are all actually the blood vessels which are floating in the vitreous cavity, and they are on the inner layers of the schisis. So on the OCT you will see the typical splitting of the retinal layers, and most of these patients, unless they develop a rhegmatogenous element, we just need to observe. So there is no treatment for this degenerative condition, we just need to observe. So there is no role of any laser or anything, just unless the patient develops a schisis retinal detachment, we don't treat these patients. Again, these are some of the patients where you have got a retinoschisis, bullous elevation. So the next group of vitreous floaters with whitish and yellowish objects are very commonly asteroid hyalosis. So they have got some typical features. One is that most of the time you can see these floaters, but the patients may not always complain of floaters, and their vision may be excellent. So that's because the light can pass through that, and the shadows which are casted on the retina are very small, so they don't disturb the vision. And on ultrasound, suppose this is a patient of mature cataract, many times we get referred that this patient of cataract with vitreous hemorrhage. So on ultrasound, it has got a very typical feature. It has got a clear vitreous anechoic part behind a clump of vitreous opacity. So this is a very classical finding on the B scan, which is very characteristic for asteroid hyalosis. So you will see a clear anechoic area of the vitreous, which is pre-retinal. So suppose you have, this is a patient of diabetic retinopathy. So in a case of asteroid hyalosis, we need to do a proper slit lamp examination, reduce the size of the slit beam, and look for the diabetic retinopathy in diabetic patients. And in case there is a proliferative changes or thing, you can do the PRP laser. If it is more dense, then you can take the aid of a OCT, because this is monochromatic light can pass through the asteroid hyalosis, whereas white light will get backscattered. That's why you're not able to see the fundus. But if you use a monochromatic light like a OCT or autofluorescence, you are able to capture the retinal details. So in the OCT, you can see in the right eye, there is no traction element, so he has got undergone PRP. In the left eye, there is a traction. You can see there is a retinal elevation, and this indicates that, and because of the density of the opacity, we have to do vitrectomy for this patient. But these patients of this asteroid hyalosis can have a lot of vitreous cases, and it can be missed, and then they can develop a detachment. So vitrectomy in asteroid hyalosis should not be taken lightly. So autofluorescence is a good modality to image these patients of asteroid hyalosis. So this is a patient of proliferative diabetic retinopathy showing multiple NVE on the FFA, and this needs to be lasered. But you can see that it's very difficult to see the laser spots because of the asteroids. So you can take care of the, you can do the wide field autofluorescence of this patient, and you can see that the fresh laser spots will appear hyper autofluorescent, and the uncovered areas will be showing you where the laser has not been done. So it helps you to guide where you have done the laser, where you have not done the laser. And of course, if the asteroids are very dense, then you will have to do vitrectomy along with that. So a variant of these vitreous white or yellowish floaters is cholesterol deposits inside the eye. So in this syncytial scintillans or the cholesterolosis, patients have got a primary ocular pathology that could be a old trauma, inflammation, vitreous hemorrhage. So after that you get cholesterol deposits. So always these patients have got less vision, suboptimal vision because of the underlying disease. And these patients could be young and they could be bilateral, and they will have visual impairment because they have got a pre-existing disease, unlike the asteroid halosis. So these are again rare case. You will not see it very commonly. This is a amyloidosis. So in case the vitreous opacities are very dense, causing problems of the vision to the patient, you will have to do a vitrectomy with PVD induction and base dissection, because residual vitreous left, the amyloidosis again proliferates in that area. So you have to do a complete vitrectomy. So you can have other kind of opacities in the vitreous which are white and yellow. This could be residual triamcinolone crystals, like in this patient. Sometimes you are given intravitreal injections, and these intravitreal injections can precipitate like vancomycin and ceftazidime, and you can have whitish opacities. So these are some of the things. If you have got signs of inflammation, then this is vitritis. So examine on, don't forget to examine the anterior segment, very important. So the key to whether it is vitritis or not is to exactly take the proper evaluation of the anterior segment. So if you have a look, in a case of vitritis, always look for a spot, I mean whitish or yellowish opacity on the retina. So this could be an infective pathology, and most common cause is toxoplasmosis. So you can have acute retinal necrosis. So basically, to summarize the case of vitritis is that you have to do a good examination of the retina to rule out infective conditions. So this is one of the case of ARN, which was treated with periocular steroid, and it went on to involve the macula. So any case of vitritis, don't take it lightly, rule out infective causes, and then you should treat. So non-infective cause like intermediate uveitis is a diagnosis of exclusion. So on endophthalmitis, again they can have anterior segment signs of cells, flare, hypopyon. It's easier to diagnose. Only thing to remember is that in an opaque anterior segment where you cannot see the fundus, ultrasound may not be very reliable. So you have to rely on the anterior segment signs and the overall clinical picture to decide about the diagnosis. So some of the distribution of these floaters, distribution of these opacities can point to some diagnosis. Like in this case of fungal endophthalmitis, you can have these string of pearls and clumps which are actually pointing towards a candida infection. At extremes of age, beware that these patients can have malignancies. So this is a young child with vitreous floaters, vitreous opacities, whitish vitreous opacities, but these are actually seeds from the retinoblastoma. And you can see on the right top there is a retinoblastoma lesion. So these are retinoblastoma patients with vitreous seedings. And at elderly or middle-aged patients, if they are associated with subretinal infiltrates and other things, they can be a presenting feature of lymphoma. So there are various signs which are there on the OCT which helps you to clink the diagnosis apart from the histopathology. Again, differentiating old vitreous hemorrhage and vitritis is the key, is to examine the anterior segment properly. So in the anterior segment, if they are absolutely quiet, then it can be. So this is another patient of vitreous opacity. This is a retinal dialysis with a vitreous base avulsion. So thank you. I could discuss some of the causes of the whitish or yellowish floaters. Thank you.
Thank you, Dr. Bhomaj, for an excellent presentation.